This is a team that is probably one of the later ones to the blocks and just going like full speed. And we're really, really psyched to see how quickly that team is moving and now sharing that story today. This is the part of the program that's the numbers part, okay? Peter gets to do the fun stuff after me. So I'm gonna try to bring some numbers to life a little bit for you here in terms of quality and in terms of money, and really try to give you that side of the picture today, okay? There are, as Jessica mentioned, there are a lot of parts of the program. There's workforce, there's technology, there's the B1 integration projects, there's all of the really great work that's being done with the community projects, and some of the numbers shine lights mainly on the B1 part of our project, okay? So don't want anybody to feel left out, but those that are reporting the clinical quality measures are getting a little bit of extra attention in this part. So if we can go to the first part, the next slide, please. This is, and feel free to do any applause if you feel so moved, because this is really great. We're at 2,677 Medicaid members screened this year. No, this is a big deal. So, thank you. This is a huge deal. Okay, this was at in the hundreds when we began. Okay, and now we're doing this, and almost every project is taking off with screening. Okay, I was trying to do some research on high blood pressure, and I looked at our numbers. We actually are measured on high blood pressure screening. Our IDN doesn't do anything at all for high blood pressure, but we're measured on it. But the really cool thing about it, and that's beside the point, but the really cool thing about high blood pressure screening is we screened 18,000 people in the same time period, okay? And the reason I raise this is if you think back, and for those of you who went through it, when high blood pressure screening was introduced, lots of things had to change. People had to buy new equipment. They had to look at the flow of the office from front to back and think, where are we going to put this into the flow? How are we going to inform our clinicians when we have an abnormal result? What are we going to do? Are we going to measure this if we can't do anything about an abnormal result? No, we need to actually have some follow-ups that are possible, and we need people to do those follow-ups. We need to collect the data. We need to be able to have somewhere to put that data, and we need to report it. And now the payers are coming after us, and they're paying us on our high blood pressure screens. 18,000 is where we are as an IDN right now. There are only 3% that we miss right now in high blood pressure screen. That is a path. That shows us a vision for what is possible. We're actually doing something that's simpler here. We're just giving Medicaid members an opportunity to ask for help. An opportunity to ask for help around substance use, suicide, mental health, and social determinants of health, such as housing. And I'm really excited about this number that shows we've left the runway, we're taking off, and we're following the same path that we saw with high blood pressure screening, where it becomes a ubiquitous part of a patient's care. So, okay, second big number here. This is 1,407 depression and substance use follow-ups. That means for every time there was a discovery of substance misuse or a discovery of depression, there was some follow-up action taken by the clinical teams. Also a big deal, so if you feel like... These have different denominators, so don't try to compare these two numbers. But what's important here is the response is following the screening. Okay? When many of you were here 4 years ago, the big worry in the room was, if we ask and we find out, what are we going to do about it? We couldn't possibly ask a question that we can't respond to. Okay? We have evidence that we have the capacity to respond now. Okay? And then finally, we have 32 active shared care plans for our most high complex Medicaid members. So that's, thank you. So, these are very global, trying to touch everybody. These are very, very concentrated on trying to address those, like in the case that you heard from Alice Peck-Day team, people that have a lot of complexity across many different organizations. And each one of these takes a lot of energy to set up, and they're taking off all across. So all good news, okay? This is a graph that shows, this is the Clear the Runway graph, okay? Last 6 months, we took off on screening, and the bottom line is follow-ups. Follow-ups followed, okay? That's a big deal. If the follow-ups hadn't followed, we'd be having a very different discussion right now about everybody would want to back out of the screening, okay? So 2 really great indicators that we're able to screen and we're able to follow up, okay? Performance, you've seen this slide before. I stole the J-Code pain thing. We are finally near the end of this kind of pain curve for the quality data reporting. Most places are now not talking about fixing their data nearly as much. They're starting to talk about standardizing their processes, making sure the clinicians are entering things in ways that are standard. Some of you that are really good at quality improvement are doing, and this is a good thing, you're dropping back down here like over and over again, and that's good. You're like, oh, this data is awful. And repeat. And we thought we had it, but oh God, we're back in it again. And that's okay, that's expected, okay? And so some of the data is still not as good as we'd like it to be on the quality side. But a few more cycles and it's gonna be pretty good. And certainly good enough to do 2 things. One is to put numbers out there that can help our pay-for-performance system. And 2, for you to be able to do clinical quality measure improvement activities on some of the measures, okay? So there is light at the end of this tunnel, and it's only a few months out before we're at the point where the data is reliable and you don't have to spend nearly as much time on data integrity. We can move on to the good work, okay? All right, more applause, please. These are some shout outs, okay? We have several partners that are leading with screening. Phoenix House is at 100%, West Central Behavioral Health is at 89%, Monadnock Family Services at 70%, and Counseling Associates is at 67%. So a round of applause for all those. Now, I don't want to diminish the leaders in any way, but these guys all had head starts, okay? These organizations all had something in place to build upon. They had a really strong foundation to build upon and improve upon. We've got some new players that had to start from scratch with new processes, wholly new processes. And I'd like to call out kind of the Clearing the Runway group here, which is now Dartmouth Hitchcock Lebanon has 319 screens in the last 9 months. Valley with 231 in the last 9 months. Cheshire with 163 screens, and Newport with 42 screens in the last 6 months. So applause for everybody who's taken off these. So thank you to all of you for taking off. The second part is around follow-up, and our leaders with following up to SUD and depression screens are with Counseling Associates at 99%, Phoenix House with 94, MFS with 84, West Central with 56, Cheshire with 55, and Monadnock Community Hospital at 49%. These are all above the state target. So these organizations are all helping us bring in funding around this particular measure. So please shout out for these groups. All right, now for the money part, okay? So Jessica teed this up really well. We're in a bit of a cycle now, okay? If you do good work, together we do good work. The state measures that through our quality measures that take a narrow set of what we're doing and they measure it, and all of our money is now tied to that, okay? So we we were last year only a quarter of our revenue was tied to revenue. It was tied to performance. Now it's all tied to performance. Okay? And performance has 3 different flavors. And part of it we control very closely. Those are clinical quality measures. And then about a third of our revenue is based on clinical quality measures. That's the stuff you put into the data portal, the quality, the reporting service. That's the data you get from me monthly in a dashboard, and that's the data that you see and touch every day. There's another 2/3 that's hanging out there in the background, and it's all going through your claims. So anybody who's billing in our entire IDN, those that are in the room, those that are in the IDN, or anybody else who bills in our geography, your data is, your claims data is producing another set of metrics that we're paid upon. Okay? So people that we haven't even been able to engage here, as well as those of you who bill in this room, are contributing to that part of our metrics. And then finally, at the very end, not yet, they haven't done this yet, but they're going to do patient questionnaires, and that is going to weigh in only about 3%. I'd love to see that be a much higher number, but they're going to ask the patients about experience with integrated care in the last year of the waiver, and that also will be impacting our payment. Okay? Next slide, please. Okay. This is a review. I've showed this to you this will be the 3rd time, but this is what the measures encourage us to do. And I'm going to go through it one more time because I think it's important to hear it every maybe 3 months. Okay? Provide positive patient experience. Screen and follow up for SUD, depression, intimate partner violence, high blood pressure, lipid disorders, tobacco use, and obesity. Follow up quickly on community mental health center and substance use treatment intakes. Manage the chronic diseases within the behavioral health population with a focus on high blood pressure, diabetes, COPD, and asthma. Reduce avoidable hospitalizations and readmits. Follow up on ED and inpatient discharges. Manage medication adherence. Provide adolescent well care visits. Send hospital discharges when people leave the hospital. And prescribe opioids cautiously. Okay? That's our measure set, focuses on these things. We can't possibly do everything here, so we are encouraging you to focus even more narrowly on the things that you want to change in the next 15 months, and we'll let the measures catch those pieces. Okay? Next one. These are the organizations that are carrying the load for clinical quality measurement. Our 2 mental health centers, our community-based counseling and SUD treatment centers, and our primary care centers. Okay? So these are the people that are measured on that 1/3, the clinical quality measures. Okay? Most of those metrics don't pick up what our community partners are doing, and so we have to rely heavily on this group to carry us. The things we're doing really well in the measures world. We have met all of our pay for reporting measures, so everybody's reporting properly. We're on target for hospital use of hospital emergency departments within the behavioral health population. We are on target for potentially avoidable emergency department visits. These are the big measures that payers pay a lot of attention to because they think the greatest cost is associated with hospitalizations and avoidable admits. So we're doing really well in that area. We're also, for the new year, we're on target for following up. We saw our follow-ups earlier. We're actually above the state target for following up on substance use and on depression. We're below target on some other areas. Following up after hospitalization for mental illness within 7 to 30 days. Those 2 measures where after there's a hospitalization for a behavioral health condition, there's follow-up in the mental health centers quickly. We're off target on that one. We're also off target on the opioid measure, although the state is looking at replacing this particular measure because they've found a better one that's more appropriate for our state. And we're also for how good our assessments are right now, we're off target. We're actually below what the state target is for those things. But we're not going to be deterred because that is going in the right direction and fast. So, okay. This is the money part. Okay. We have a lot of uncertainty in the budgets, and that's the reason your contracts are built the way they are. Okay. Those of you who just signed an 18-month B1 integration project, there's the ability in there for you to draw down money that we bring in for performance. Okay, so there's a big piece of your contract that is contingent upon the IDN doing well. Okay, those of you, and Jessica just mentioned workforce. As soon as we bring money in, we're able to release it for things like workforce. So we try to draw down performance money and then push it back out. We're in this period where we're at about 1.1 million each 6 months is our estimate for the amount of revenue the IDN's able to bring in and then push back out. Okay? It can be as low as 0 in this model. Okay? Based on our performance pay and based on the uncertainties of the money in the state, it can be as low as 0, and it can be higher than that 1.1. It can approach almost 2 if all conditions are right. Okay? So we've created the situation where we can try to earn as much of this as possible through our metrics and try to push that out. Okay? And if there are any questions about that, we'll take those in a second. Okay. Our focus areas right now on the measurement side, and Peter's going to address this a lot more in his piece, but really trying to do our Plan, Do, Study, Act, kind of a continuous improvement cycle on improving our screening and our follow-up, on addressing either primary care or addressing ED utilization. So each of the B1 contracts has a piece of a continuous improvement project built into them, with the hope that each of you will take some help from coaching and go through some improvement processes with the data that we can provide. Okay? And then we'll take questions if you've got any about quality measurement or about the way our funding works.
Could you explain a little bit more about the ED use and behavioral health in the EDs as a performance piece that you referenced? And then how is follow-up on a screening for substance use defined?
Okay, so Sean with 2 questions. The first is the measure around ED use. So there's a measure that looks at frequent emergency department use for those that have a primary diagnosis that looks like behavioral health. So and this is calculated using claims data, and the state gives it to us with about a 10-month delay. And we're ahead of the rest of the state. I believe we lead the state in this particular measure. And we're well ahead of the target at this point. So to be better at this measure, we're basically, to do well on this measure, we're trying to address behavioral health needs outside of the emergency room in the hospital. Okay? And then your second question was about follow-up. So the follow-up measures are all a little bit, they're all very nuanced, but there's some evidence in the medical record that something was found. A positive result was found for depression, a positive result was found for substance misuse, and then something was done about it. And that can be a referral, that can be an expert type screen brief intervention referral to treatment process that happens. And the trick is a lot of these things are not well recorded in some EHR systems. So your clinicians may actually be doing all of this work naturally, but getting best practice alerts or different ways for clinicians to chart the fact that they did that follow-up is the trick here. And just correcting the data has actually brought our numbers up quite a bit. So did that get you? Okay, thanks, Sean. Great questions. Yes, Chris. I'm going to bring.
Know how the matrix show us compared with other IDNs throughout the state, and if we can take anything, if we're not in an area where we need to be, can we take any lessons from others, and how's that all come together?
Thanks, Chris. So the question was, can we compare ourselves across the state and take learnings from others in those places? There is a group that looks at a very small subset of the measures periodically, maybe quarterly at this point. There is not robust sharing at this point, but I think that's okay given where we are, with the measures being pretty new to everybody. But if we don't see that, the goal is what you're talking about. We should be seeing that in this year. This is a year to spread, to learn, and to share across the state. So we'll do what we can to push that.
Are these on the website?
On the what?
Will these be downloaded to the website?
No. But I think our
The video
perf-
of this will be, and I can share the slide.
yeah. Our performance measurement is public, though. We put out a dashboard of 26 measures on a monthly cadence that's fully public. So the intention is there to share widely. The obvious next step is, hey, Phoenix House, you're doing amazingly at this. What can we learn from you? Or MFS, you're just knocking it out of the park on screening and follow-up. What can we learn from you? That's the step that has not been taken like it could be statewide. That's the opportunity missed so far. Thanks, Chris. Other questions? Yes. I'll give you the mic here. Thank you.
So looking at the avoidable ER visits, is it coding? Is it presenting diagnosis versus discharge diagnosis? Someone's presenting with chest pain and then the discharge of actually the anxiety. Is there something to look at with a deep dive in coding? I'm asking a very complex question.
I don't know the answer to that, but it's a good question. I'll find out.
We can get that. I don't know if that catches the very typical case of arrhythmia with a hidden anxiety diagnosis, or whether it doesn't. But they've got a big giant list of evidence-based diagnoses that should be avoidable, and they draw off that and to see if people are coming in for those. So thank you to Jamie, always knows the answers on these. So, okay. Any other questions, please? Okay, so we got really wonky there for a minute. Okay, so I want to draw us back. The important piece of this is that we've had an opportunity to use federal and county funds to do some kind of big change work, to introduce something that's as powerful as blood pressure screening is across our IDN, to be able to recognize when patients have issues in substance use, mental health, and with social determinants of health, and to do something about it. And the work is starting to take off, and so that's all due to you. So I'm going to get off the stage, but please give yourselves and each other a big round of applause for all of the work so far. Thank you.